All right, well, we're going to get started. Thank you all for coming today, and hope everybody has great plans for the weekend, and happy Mother's Day in advance. We are continuing our series of our Chief Resident Grand Rounds talks. And to introduce Haley, we have Dr. Andy Coyle, our Residency Program Director.
All right, great. Thanks, Lynn. And welcome, everyone. Thanks for joining in person or virtually. Really excited for the continuation of our Grand Round series. And our speaker today is Dr. Haley Probst. Haley is a graduate of the University of Wisconsin School of Medicine and Public Health. And we are very fortunate that she chose to continue her training as a resident here at UW, where she was a member of our health equity pathway. As a resident and a chief resident, Haley has been active in a huge number of quality improvement and research projects under the mentorship of Drs. Tischendorf and Kennick, one of which she'll be talking about today, contingency planning in patients who inject drugs. This work has been presented locally, regionally, nationally, and Haley was a recipient of an excellent award from the UW Health Quality Improvement Symposium. As a resident, Haley really distinguished herself as an outstanding clinician, a wonderful communicator, and an advocate and leader amongst her peers. As our general internal medicine chief resident this year, she's been a wonderful mentor to both our primary care and categorical residents, a skilled, thoughtful, enthusiastic, and fun teacher, and a really incredible mentor and leader for our residency program. So we're incredibly grateful for all that Haley has contributed to our residency, our community, and our program over the last several years. Haley will be continuing her career as a hospitalist at SSM St. Mary's here in Madison, where I know she will be outstanding. So I'm really excited for today's talk, and please join me in welcoming Dr. Haley Probst.
Thank you so much. That was very kind. Over the course of the next hour that I'll be speaking, in America, 10 to 12 individuals will die as a result of their drug use. By the end of the day, that number will be 275. And by the end of the year, that'll be nearly 100,000 people. Today, we're going to be talking about patients who inject drugs with serious bacterial infections, and specifically contingency planning in individuals who may leave the hospital before medically advised, to see if you can make a choice that will potentially save that individual's life. I don't have any disclosures, but I want to take a moment on this slide to make a disclaimer. I'm going to be talking today about patients who inject drugs, obviously, and this is commonly a marginalized population that's often talked about in a derogatory way or a non-patient-centered way amongst like our population here and also providers. I will do my best today to talk in a patient-centered way, but if I revert back to any language that may be more colloquially acceptable or non-patient-centered, I apologize in advance. I too recognize that I have space to do in this area, or sorry, work to do in this area. All right, so I have 6 objectives to get through today. We're going to talk a little about the scope of injection drug use and its complications that result from it. We're also going to discuss the standard of care for serious injection-related infections. We will specifically talk about infective endocarditis because it has the most clear guidelines of many of the serious injection-related infections. And we will talk about acceptable alternatives where the standard of care cannot be met. We will also discuss the perspective of individuals who decide to leave our hospital before medically advised and share evidence around contingency planning, specifically contingency antibiotics in these patient cases. We will also examine how we are doing here at UW and what we can do to be better for these patients. This is a roadmap slide. So across the bottom, you will see the kind of 7 areas that we will discuss today. Again, it's going to be the scope of injection drug use, the infection risk, standard of care, but then we'll discuss before medically advised discharges, the role of contingency antibiotics, the state of care at UW, and what we can do as providers to do a better job of taking care of these individuals. First, we're going to talk about the scope of injection drug use. Oftentimes, I think when we think about injection drug use, we think about people who fall into kind of 2 buckets, individuals who use opiates and individuals who use stimulants like methamphetamine or cocaine. But then we're also going to discuss a new kind of emerging drug, which is called xylazine, and the impacts of that on our patient population. All right, so first to discuss opiate overdose-related deaths in America. There's been kind of 3 waves that we've seen so far. In the late 90s, we began to see an increase in prescription opiate overdose deaths, likely related to pain being treated as the 5th vital sign and the increase in prescription of opiates. Then in about the 2010 era, we start to see heroin emerge as another drug that is causing a lot of overdose-related deaths. And then about in 2013, you see this large exponential increase in overdoses related to the contamination of our drug supply with fentanyl. If we look closer to home, we have here a map of Wisconsin. All of the counties here that are represented in blue or teal have data regarding opiate overdose related deaths for the last several years. As a state, we have a rate of 24 deaths per 100,000 individuals related to opiate use. The counties that are represented in the darker teal are the ones that are doing the worst. Dane County is unfortunately one of them. We are very close to that mean number of 24. Milwaukee County has a little bit higher rate than we do, but by far the worst county right now is Jackson County here. Jackson County is experiencing 48 deaths per 100,000 individuals. We take a look closer to home. This is data specifically for Dane County. We have really good data over the last 3 years to look at by month how frequently individuals are dying from opiate overdoses. The bars that you see in the dark purple represent numbers from 2022. And as we kind of go through time, as you move to the blue bars, those are a little bit less. And in 2024, those dark navy bars are a little bit less kind of globally. And so we are seeing a decrease in the rate of opiate overdose related deaths. Some of that has been attributed to the COVID-19 pandemic, worsening social isolation and mental health conditions. And so we see that peak in 2022. And as things kind of returned to normal and the world began to open back up, a lot of those mental health concerns have gotten better because individuals have more or have less social isolation. And so as a result of that, we may be seeing a decrease in opiate overdose related deaths. There are a lot of other like public health factors that are at play as well. So I don't want to dismiss those, but this is kind of one of the kind of leading explanations for now. So now moving on to talk about stimulants. This graph that you can see on the top of the screen is related to cocaine overdoses. The dark green bars represent the number of individuals who died each year in Wisconsin from cocaine-related use. And the kind of lighter green bar is the cumulative number of deaths over that same time course. So in 2014, we saw 101 individuals who died from cocaine-related overdoses. And then in 2023, that number had nearly increased by 8-fold to 757. That same trend is seen amongst other psychostimulants, specifically methamphetamine. So again, you can see in 2014, we had 43 related methamphetamine-related deaths. And then by 2023, we had 387. Again, nearly an 8-fold increase. You may ask yourself, what is causing this increase or what is driving it? And that is likely contamination of that drug supply, again, with fentanyl. Many states actually test all of their seized drugs for contamination with fentanyl. Wisconsin is not one of those states, but Ohio is, and they actually have a really large repertoire of data regarding this. So this bar graph is actually from that data. Over the course of the last several years, they have tested all of their methamphetamine and cocaine for contamination with fentanyl. In 2014, down here, you can see the numbers. In pink is methamphetamine, and in red is cocaine. Less than 1% of both of those drug supplies in 2014 was contaminated with fentanyl. But by 2021, the last reported year that they were sending out data, they had 4.8% of their methamphetamine contaminated with fentanyl and 16.8% of their cocaine contaminated with fentanyl. Other states that have a less robust repertoire of data are reporting now that in the years 2023 and 2024, that nearly 15 to 20% of both their cocaine and methamphetamine supply is contaminated with fentanyl. And so that is what accounts for the fourth wave of the opiate overdose related deaths. So in 2015, we began to see another upspike in overdose related deaths that were fentanyl and stimulants combined. Okay, so now we've talked about the kind of two most common categories of drugs that are used intravenously, but I also want to talk about xylazine. This is an emerging contaminant that many of you may have heard about in the news. Stereotypically, this is used as a veterinary tranquilizer because of its alpha-2 antagonism. It causes CNS depression, bradycardia, and hypotension, but it's increasingly found in our fentanyl supply. What has made it make headlines is the skin and soft tissue consequences of using xylazine. I'm going to show some pictures now, so just kind of beware. These are what the skin ulcerations and abscesses tend to look like with xylazine use. They tend to happen on extensor surfaces throughout individuals' bodies. These skin findings are typically remote from the site of injection. They can happen within hours to days of injection, or they can happen in a delayed fashion weeks later. The picture that you see here that's labeled 1 through 6 is actually the evolution of somebody's skin involvement. And typically what we're seeing is that they will have these like cratering wounds because they're just obliterating their capillary beds in these areas. They're very difficult to treat without the use of, or without the involvement of burn nurses or burn surgeons. So because xylazine is increasingly an adulterant in our drug supply, there's been a lot of a lot of research recently into learning more about the medication. UNC Chapel Hill is actually one of the universities that's kind of taking the lead on this. They've done many studies to look more into the effects of xylazine. And they think that they have found kind of 3 new pieces of data regarding xylazine. One is that it potentiates the opiate effect, meaning that if it's used in combination with something like fentanyl, people tend to have longer lasting effects of the opiates, and they go into withdrawal on a kind of a delayed basis. They also recently found that xylazine itself is also a full agonist at the kappa opiate receptor. And for a long time, xylazine was thought to not be responsive to naloxone. But recently, in an animal model, specifically mice, they administered xylazine. And then after a kind of a standardized time later, they gave those mice naloxone, and they were able to precipitate withdrawal. It's not the same type of withdrawal that we would see in opiate overdoses, because this drug also has alpha antagonism, but it should be used anytime that you suspect an individual has a xylazine overdose. Okay, this is a little bit of a detour from the point of my topic, but I thought it was too interesting to pass up. But xylazine actually has been recognized to potentially reduce the rate of opiate-related overdose deaths. So if we look at a map of America, the number of opiate overdose-related deaths are really decreasing here on the eastern seaboard. And as we move kind of westward, we are seeing kind of diminishing reduction in opiate overdose-related deaths. So here in the Midwest, we're seeing a slight decline. Across those mountainous states, they're starting to see a decline. And then across the western states, they are not seeing really a decline yet at all. The same xylazine actually follows that same pattern. So UNC Chapel Hill also has a street drug division, and they looked at all of the fentanyl, several fentanyl samples from across America to see how frequently they were contaminated with xylazine. We take a look at this graph up here in the corner. This is the representation of the state of Pennsylvania. Over time, from 2023 to 2024, they tested multiple samples of fentanyl and found that nearly 75 to 100% of them were contaminated with xylazine. In the Midwest, here we have Wisconsin and Michigan. About 25% to a third of our drug supply is contaminated with xylazine. And then as you move across to the western states like Washington, Oregon, and California, it's usually around like 10 to 15% of their drug supply is contaminated with xylazine. And so you may ask, so why are those two things related? So xylazine, since it potentiates the effect of opiates that are used, people tend to have a longer lasting effect from the drug, meaning that they need to use less times in a day to stave off withdrawal. And so instead of somebody using 3 to 4 times a day, they may be using 2 to 3 times a day. The highest risk of overdose is right after using one of these drugs. And so if you're using less frequently in a day, you're at lower risk of overdose. Also, individuals who inject drugs are actually quite terrified of having these skin and soft tissue consequences of xylazine. And so it's forcing them to think about alternative ways to use the drugs that they're ingesting. So that may be snorting, smoking, or taking it orally. Okay, so I apologize again for that detour, but I thought it was too interesting to pass up. Next, we're going to move on to talking about the infectious complications of injection drug use. This will be a review, obviously, for most of us, but thinking about viral complications, there's really the big 3 bloodborne viral infections: HIV, hepatitis B, and hepatitis C. Another consideration here to think about would be hepatitis A, that tends to be clustered amongst individuals who inject drugs together. Usually that's because of poor hygienic practices. Hepatitis A, as a reminder, is not bloodborne. It is transmitted via the fecal oral route, and so tends to be people not using potable water to mix their drug supply, licking needles, or not having good hand hygiene. Okay, so then thinking about bacterial complications, I have 9 here on the screen, but there are many, many more from injection drug use. The things that I think that we are seeing most commonly tend to be bacteremia, osteomyelitis, infective endocarditis, but really the list goes on from here. So now we're going to focus in on the standard of care for serious injection-related infections. We'll talk generally, and then we'll focus in on infective endocarditis. So generally speaking, IV antibiotics are really the mainstay for all deep-seated infections. There has been a lot of interest recently into looking into partial oral courses or long-acting injectables. There is some pretty good data for the general population, but not good enough yet to reach standard of care. However, when we look at patients who inject drugs, the data is really mixed. People who inject drugs tend to kind of fall off providers' radar more easily, and they tend to have more severe complications. And so for them, obviously IV antibiotics will probably remain the mainstay of therapy. And then another principle is that patients who inject drugs are less likely to be offered PICC lines for things like outpatient antibiotic therapy. This means that individuals who inject drugs are often in our hospitals for 4, 6, sometimes 8 weeks or longer for these prolonged IV antibiotic courses. So specifically now we're going to focus in on infective endocarditis. We're going to talk about the AHA guidelines that were released in 2015 and then endorsed by the IDSA. I'm going to gloss over this. This is a very long document, and I'm going to kind of put it down into 4 main points that were talked about. So first is the diagnosis via Duke criteria. This is something that I bring up because for those of you who don't know, the Duke criteria were actually updated in 2023. So there are more stereotypical organisms that are now included. There's more imaging modalities that are also now included. So beyond TTE and TEE, you can also do cardiac CT or PET CT as well. And then there is also more risk factors that will get you minor criteria, specifically having a prosthetic valve. And then thinking about the next point, they recommend obviously ID consultation for all of these individuals who have infective endocarditis. They are really going to be the ones that tell us the start date of somebody's antibiotics, the end date of someone's antibiotics, and what antibiotic is the most appropriate and for what duration. And then third point in the document is to kind of discuss the acceptable antibiotic regimens. It is 4 to 6 weeks of IV antibiotic is the standard of care. Obviously, the duration and the antibiotic choice is dependent on the infective organism. And then lastly, the only time that this document really references patients who inject drugs was to discuss cardiac valve repair versus replacement. Repair is always preferred over replacement because of their risk of recurrent infection. Okay, so now the reason that I glossed over the prior AHA guidelines is because there's actually a new statement that came out of the AHA in 2022, specifically for patients who inject drugs with infective endocarditis. And this was put together by a group of individuals who are considered experts in the field of infectious disease, addiction medicine, and cardiothoracic surgery. And they really made the point about 3 things regarding patients who inject drugs. 1 was the treatment of their addiction, 2 was the treatment of their infection, and 3 was the considerations for valve surgery. And we will go through kind of each of those in more detail here. So for integration of addiction consultation, really what the principle here that they shared is that the treatment of the underlying infection or underlying substance use disorder is the treatment of their infection. So you would be remiss to not give them treatment for their opiate use disorder in addition to their IV antibiotic therapy. And so they're in support of involving addiction medicine at all times and considering consultation of mental health services at your institution. They also recommend medication for opiate use disorder like Suboxone or methadone for all individuals who are willing to take it for opiate use disorder, and then to discuss harm reduction strategies, which we'll get into more detail in later. The data that they actually present to support these recommendations is that there have been multiple studies that show that addiction medicine consultation has been correlated with better patient outcomes. So there was a study out of WashU where they looked at individuals who received addiction medicine consultations during a hospital stay for a serious injection-related infection versus those who did not. People who had addiction medicine involved in their care were more likely to be started on medication for their opiate use disorder. They were more likely to finish their IV antibiotic therapy inpatient. They were less likely to discharge before medically advised, and they were also less likely to be readmitted at 90 days. To really show that point, they actually included a readmission-free survival chart in their study. And essentially what they looked at is individuals at 90 days who had an addiction medicine consultation here in blue had a readmission-free survival at about 80%. So only 20% of them were getting readmitted. And then those who had no addiction medicine consultation had a readmission-free survival of less than 60%. So more than 40% of them were getting readmitted. So about double the readmission rate if you don't include addiction medicine in this person's care. Okay, so now we'll talk about the antimicrobial perspective here. So again, they reaffirm the standard of care being 4 to 6 weeks of IV antibiotic therapy that was previously mentioned in the AHA guidelines. However, they discuss emerging non-standard alternatives for care for patients who are either unwilling to stay in the hospital or can't for some other reason. One consideration was actually outpatient antibiotic therapy in low-risk patients through a PICC line. This is really only undertaken by a few institutions nationally, and those institutions tend to have wraparound services in the outpatient setting. They have a multidisciplinary clinic with a lot of social work staff, a lot of nursing staff to prevent these individuals from being lost to follow-up. At those visits, they're usually meeting with an addiction provider, a cardiothoracic surgeon, and an ID provider. Again, not something that most institutions are considering taking up just because of the intensity of services that are needed. But the second thing they bring up is the recommendation for contingency antibiotics on before medically advised discharge. And that's really what the bulk of this presentation will be about in a couple minutes. All right, and then for cardiac valve surgery, they again reaffirm that valve replacement should be the last resort. So thinking about percutaneous debulking with like an angiovac procedure with interventional cardiology, or considering valve repair should always be your first kind of choices in this patient population, again, because of recurrence risk of infection. Okay, so now we're going to talk a little about before medically advised discharge and why people leave our hospitals. Just to kind of make a note here, obviously I'm not using against medical advice, but these are essentially interchangeable terms. Before medically advised has less of a negative connotation than against medical advice, and that's why I will be using that. Other terms that are kind of emerging in the space are patient-directed discharge as well as another synonym. So first I want to just look at the trend in before medically advised discharge. So if we look, this chart really shows us before medically advised discharges over the course of 2016 to 2020. At one institution, they looked at really all of their admissions and the rate before medically advised discharge. Those are represented here in navy. So as you look across the bottom, about 1% of all, or 1.5% of all comers are discharging before medically advised. But when we look at those who are represented in orange, these are individuals who have opiate use disorder and are coming in with serious injection-related infections. Back in 2016, they were discharging at a rate of about 7.5%, but by the end of 2020, they were discharging at a rate of 17.5%, so nearly a 10% increase at this institution. But globally, we are seeing people are discharging at a higher rate who have opiate use disorder and a serious injection-related infection. You may ask yourself, why are they leaving? And there's a large repertoire of data out there regarding why individuals leave before medically advised. These are just 3 of the articles that I read in preparation for this presentation, but it really boils down to usually about 4 different kind of underlying themes. And this is what they are. So inadequate withdrawal treatment, inadequate pain control, negative interactions with staff, and then boredom and isolation. I'm going to read a couple quotes that patients said to kind of really give us their perspective. So in regard to withdrawal treatment, individuals said diarrhea, vomiting, sweats, chills. It's just like the flu times 10. I would rather go through childbirth, honestly, than withdrawing. So it's not that I want to get high, it's that I have to. So again, inadequate withdrawal treatment is something that a lot of patients suffer with when they come into the hospital. We're fortunate here to have a really robust order set that we can look to for some guidance, and we'll talk about that in a little bit. And then inadequate pain control was next. An individual said, I can't even think about getting my drug use under control until I figure out how to get my pain managed and my health concerns under control. When my pain gets really bad, that's when I want to leave and go use. So I think pain control is something that many of us struggle with when they're admitting these patients. They tend to come in using high doses of fentanyl, and it's really a catch-up game on our side of things to really get them to a point where we're treating their pain adequately. Oftentimes we're using higher doses of opiates than we are accustomed to, and oftentimes feel uncomfortable. However, I think the kind of point to be made here is that we have to get comfortable doing this, or otherwise individuals will leave because they know where to get the drug that they've been using. All right, and then in regard to negative interactions with staff, somebody said, in general, they tend to be a little stricter with you. They tend to be more short-tempered with you. They tend to presume what you need instead of actually getting to know the person. I think this is something that a lot of institutions struggle with. Oftentimes, these individuals are placed under, stricter surveillance, having sitters or video monitors. They're having their belongings gone through by staff members, and typically they, have visitor limitations or kind of restrictions in moving around the hospital. And then also boredom and isolation is another factor. One individual said, I'm tired of being trapped here. I don't even look out the window because I don't like to. I haven't felt the outside air in almost 5 weeks. I think something regarding this point that's sometimes hard for us to see is that these individuals, are oftentimes like fully functioning members of society outside of the hospital. They may have jobs, they may have families. And so being isolated and bored is a real factor in these individuals leaving after, 4, 5, or 6 weeks of treatment. Okay, so I know that a lot of times when I'm reading these articles, I think to myself, I don't treat my patients like that, or I don't think that my colleagues treat my patients like that. But I do want to share a story of a patient that I heard from the addiction team, the infectious disease team, just to exemplify that I think patients at our own institution are struggling with these same factors. So this is a story of a young woman. She had multiple surgeries as a child that were reconstructive in nature, and she became dependent on opiates after those surgeries. Somewhere in her late teens to early 20s, she began using IV drugs and had multiple instances of serious injection-related infections as a result of that. During her latest admission, she came in with a serious infection, was admitted to a hospitalist team who consulted infectious disease, health psychology, and addiction medicine, and really began to kind of work diligently on her treatment. She struggled in the first couple of days with uncontrolled pain and uncontrolled withdrawal, and at that time really was not engaging much in her treatment because of those symptoms. Her unit and security decided to put her on some restrictions, and she was not allowed any visitors. She had a video monitor at all times or a sitter in her room, and then was not allowed to leave her room without physical therapy or occupational therapy. Addiction medicine and hospital medicine really worked diligently to get her withdrawal symptoms under control and treat her addiction. And she was eventually put on methadone. She really kind of turned her whole hospital stay around after those symptoms were controlled and began to really engage with health psychology and infectious disease. She was willing to stay for her 6 weeks of IV antibiotic therapy. At the 6-week point, she underwent a procedure with a surgical consultant. And unfortunately, cultures from that procedure came back positive. At that time, ID recommended an additional 6 weeks of IV antibiotic therapy. She was really hesitant to stay because she was craving personal interaction with her support team outside of the hospital. She asked her hospitalist if she could see her dad. And the hospitalist consulted the ethics committee at this point to determine what restrictions this patient should be on. And the ethics committee said that since this is somebody who has autonomy, they should really not have restrictions at all. The hospitalist asked the unit to remove her restrictions, but unfortunately, they were unwilling to do so. And so her request to see her dad was denied. That is where I have lost touch with this story, but I think it really exemplifies some of those reasons here at our own institution, having initially inadequate withdrawal, symptom control, inadequate pain control, and then eventually this isolation, boredom, and negative interactions with staff. But I think something that we can all recognize has probably happened to our patients and that we could potentially do better on. Okay, so now that we've discussed why people leave before medically advised, I want to talk about the role of contingency antibiotics. Before we discuss contingency antibiotics, I just want to reaffirm that, again, the standard of care for these patients is 4 to 6 weeks of IV antibiotic therapy. So contingency antibiotics are not an alternative if somebody wants to stay in the hospital for that duration. But if they are unwilling to stay, contingency antibiotics are something that you should consider prescribing. So as a definition, contingency antibiotics are a non-standard regimen designed to be used when the standard of care could not be administered. So if someone is opting to leave before medically advised, before they finish their 4 to 6 weeks of IV antibiotic therapy or whatever ID is recommending, you can consider prescription of long-acting injectables at the time of discharge, Fortavancin or Dalbavancin. Obviously, these require a little bit more coordination with an infusion center in the outpatient setting. Or you can consider using highly bioavailable oral antibiotics like fluoroquinolones, linezolid, or Bactrim. Other considerations for highly bioavailable oral antibiotics and as an alternative would be something like penicillins or cephalosporins, which have also been used in specific circumstances. Now, I want to share with you the data behind why you would consider using contingency antibiotics. So a researcher out of WashU did a study to look at what would happen if patients discharged before medically advised and received contingency antibiotics, and what would happen if they discharged before medically advised without contingency antibiotics. And they specifically looked at 90-day readmission rates. So for individuals who discharged before medically advised without contingency antibiotics, the readmission rate at 90 days was nearing 70%. Individuals who discharged, however, before medically advised with contingency antibiotics in hand had a readmission rate of about 33%, which is really nearing what their counterparts had who actually had completed their IV antibiotic course inpatient. Next up, they wanted to look at readmission for antimicrobial failure and death. Individuals who were discharged before medically advised without contingency antibiotics had antimicrobial failure or death at a rate of about 45%, whereas individuals who had discharged before medically advised with contingency antibiotics in hand had antimicrobial failure or death at a rate of about 13%. And that again was nearing their counterpart who had actually completed their IV antibiotic therapy inpatient. And so really the argument here to prescribe contingency antibiotics is that it reduces readmission, it reduces morbidity, and it reduces mortality. Okay, so when I heard this data, my next thought was, yikes, I have never myself prescribed contingency antibiotics when these individuals had left before medically advised. And I wanted to know, what were my colleagues doing? So I worked with Dr. Tischendorf and Dr. Koenig on a quality improvement project. And our first step was to really understand what our population was doing in the moment. And so we looked at all individuals who were admitted here at the main campus between 2020 and 2022 with infective endocarditis and comorbid IV drug use. And we found 60 total patients. And so these are 60 patients. My first question when I was doing this chart review was to understand who actually had a documented plan for, if this patient leaves before medically advised, give them this. And that could have come from the primary service or infectious disease or really any other team that was taking care of them. And of these individuals, 12 of them had a documented plan. So those that are represented here in blue had a documented contingency plan in their chart that said, if this patient leaves before they complete their IV antibiotic therapy, organize this long-acting injectable or give them this oral antibiotic. 48 of those individuals did not have a plan. So 80% did not have a plan. My next question was then, where do these individuals actually end up on discharge? And so this is where it gets a little bit more complicated. But again, all the individuals who are above this line have a documented plan. Those that remain here in blue discharged before medically advised. The one here in gray completed their IV antibiotics inpatient, and the one here in black passed away. The individuals who are then below the line, again, are all those that do not have a contingency antibiotic plan. The 15 here in red discharged before medically advised. The individuals here in gray completed their IV antibiotic therapy or went to another institution where they were to complete it. And then the ones here in black passed away. The next question was then, who actually received contingency antibiotics when they left before medically advised? So that is represented here by those who are circled. So again, the 10 individuals who are here in blue are those that had a documented plan, but discharged before medically advised. 9 of those 10 are circled, meaning 9 of those 10 received contingency antibiotics on discharge. Down here, those 15 who remain in red had no documented plan, but opted to leave before medically advised, and 2 of those 15 received contingency antibiotics, or 13%. So a pretty large difference in the uptake of prescription of antibiotics, dependent on whether or not there was a documented plan. And so Dr. Tischendorf, Dr. Koenig, and I decided to do an electronic medical record intervention. We made a dot phrase that essentially was to increase the discussion and documentation of contingency plans. This was shared at the time of its creation with every hospitalist and every internal medicine resident that was employed here at UW. And it was disseminated in multiple ways. So I gave my advances on this as a resident. Dr. Tischendorf and I gave hospital medicine grand rounds. Dr. Koenig had this put in the hospital medicine newsletter. And then I also sent out a survey that had actually a really good response rate from our hospitalists and internal medicine residents that had education about the dot phrase as well. And this is what the dot phrase actually looks like. This is very customizable. People can use this however they want, but essentially it says that if a patient leaves in a patient-directed discharge manner, meaning they leave before medically advised, to try to prescribe these contingency options. It seemed like from our chart review that long-acting injectables were favored amongst the ID attendings, and so that was listed as option 1. But again, that could be altered depending on the case that you have. And then antibiotics were really kind of the second choice. The reason for this is that long-acting injectables are very hard to organize in a quick fashion. And so this has to be almost like a plan before medically advised discharge, or oral antibiotics that can be prescribed in the moment easily. And then there's also recommendations here to have follow-up with ID, and then also to alert the ID fellow if they are involved either during business hours or the next day, so that they can work on coordination if the patient leaves really without the antibiotic plan in place. Okay, so after we disseminated this, we did a chart review. Unfortunately, this was a really quick turnaround because my training here is coming to an end. But we looked back at the individuals that were admitted with infective endocarditis and had comorbid IV drug use between 2023 and 2024. And we found 22 total patients. And we're going to go through those same kind of those same kind of graphics again. So these are the 22 individuals that were part of this portion of the study. So we looked at, again, those that had a documented plan. There were 4 of them total. And then there were 18 who did not have a documented plan. Again, the next question is, where do these people end up at discharge? And so the ones who remain here in blue, the discharge before medically advised. The ones here in gray completed their IV antibiotics inpatient. The individuals here in red without a documented plan left before medically advised. All of these in gray completed their IV antibiotics inpatient or went back to another facility where they would complete them. And the ones here in black passed away. Okay, so the next question, did they actually get contingency antibiotics? So only the individuals who had a documented plan received contingency antibiotics. So reaffirming that the presence of a plan is very important. And again, those individuals that did not have a documented plan that chose to leave before medically advised, those 2 did not receive contingency antibiotics on discharge. Okay, but as you may have seen, there was not really a big uptake in the documentation of contingency antibiotics. So pre-intervention, 20% of patients had a documented plan, and post-intervention, 18% of individuals had a documented plan. That was kind of a womp womp moment for me. But every time this happens in research or quality improvement, you should really ask yourself, why was this unsuccessful? I think there was kind of 3 main reasons to think about here. So taking care of patients who inject drugs and thinking about them in a really patient-centered way forces providers to really kind of check their biases. And it takes a long time to create cultural change when you have deep-seated biases. And so it's going to take a lot of individuals to kind of start this practice to kind of get the ball rolling. And it likely needs more time than I was allowed in my course of training. And then next up is to consider the intervention that we did. There's hierarchy to interventions in quality improvement. The ones that have the most uptake are ones that you cannot ignore. So things like BPAs, but BPAs are super unpopular in medical records, and I didn't want to be that annoying resident who was forcing people to do things. And so we opted for an education-based intervention, but I think next time we might have to think about something that's a little bit more in your face that you can't ignore. And then next up was poor timing. So as we're doing this project, really we're seeing continued shifting of admissions throughout our system. So Meritor is taking care of more and more complex patients, as is EMH. And so some of these patients are getting shifted over to other areas. And so really, as you can see, our N number was kind of dropping over time. So we went from 60 to 22 patients. And then also there's increasing short stays. So there's a lot of outside hospitals who are referring to us for things like angiovac procedures. Those patients are staying for like 72 to 96 hours and then being shipped back to the hospital that they came from. And so the kind of short time span is really not where we're going to make waves in their antimicrobial plan. All right, so now that we've talked about where we are as an institution, I want to talk about what we can all do better or what our institution can do better. So the first thing to think about is harm reduction. We had talked about this earlier, and this is part of the kind of 2022 AHA updates on caring for patients who inject drugs. They recommend testing individuals for HIV, hepatitis B, and hepatitis C during all admissions to assess their risk for sexually transmitted infections. Individuals who inject drugs are typically individuals who may be engaging in higher risk sexual activity. So thinking about testing for syphilis, gonorrhea, chlamydia, or other STIs is really important while you have them captured in an inpatient stay. And then thinking about PrEP for individuals who have injection drug use and are motivated to start it. You could start that at the time of discharge. You could recommend it to their primary care provider, which most people at this point should be comfortable prescribing PrEP. And then also consider referral to ID if their PCP may not be agreeable to prescribing that. And then also considering referring for outpatient addiction care. We are very fortunate here at UW. We have the UW Compass Clinic that is run by our addiction team. They have walk-in sessions, they have scheduled sessions, and are more than willing to take on our patients. There's also New Start at Meritor, who is also willing to kind of capture some of these patients as well. And then always consider prescription of naloxone on discharge. I'm going to sound like a broken record in this portion of the talk, but I'm going to keep reiterating that to you guys. But I want to talk really quickly about other harm reduction strategies that we don't really talk about here in the hospital, but you can mention to your patient. So safe injection kits are something that you can get through the public health department here or Vivint Health in Dane County. And this is what a safe injection kit looks like. It has a tourniquet, which again should not be shared amongst patients. They have alcohol prep pads to clean the skin. And then as you can see here in this white container and in this clear container here, these are actually hookers for drugs. So this is what the one looks like from this white container, and this is the one that looks like from the clear container. Essentially what would happen is an individual would put the whatever medication they have purchased in here. They would add this ampule of sterile water, and then they would add vitamin C. This makes the mixture more acidic and less harmful for their vasculature. They would then stick this little white filter into the mixture after they've melted it, and they would essentially draw that medication up in these clean syringes, and then they would be ready to inject. The filter is really helpful in essentially filtering out any like crystalline products or kind of like continued like hard particles that would be like more detrimental to their vasculature as well. Oftentimes what also comes in these injection kits is fentanyl test strips, and then xylazine test strips are also becoming more common. So essentially as someone is cooking their drug, they can dip the test strip into that mixture to see if it contains fentanyl or xylazine, and then to decide to use it or not. And then also to decide to use it with a partner or not, so they can be monitored for risk of overdose. And then again, a lot of these injection supplies will also include naloxone. If they don't, you can prescribe it. You can buy it over the counter. You can get it from multiple, essentially like vending machines across the city. And then I also, in all of my discharge documentation for individuals who inject drugs, include the Never Use Alone hotline. For those of you who don't know, the Never Use Alone hotline is essentially a number that someone can call 24/7. On the other end, somebody picks up the phone, asks that individual where they are, and then stays on the phone while they use. If they lose contact with that individual, they will call emergency services and send them to the location that they were provided, presuming that they had overdosed on whatever medication that they were using. Okay, so now I'm going to move on to talking about withdrawal treatment and treatment of addiction. So we are very fortunate to have a really robust opiate withdrawal order set here that's used for inpatient and emergency patients. So this has kind of 4 sections to it. The first section is all the labs that you should order anytime someone comes into the hospital. The next section is vital signs monitoring and COWS monitoring that you can order. And then the next section is probably the most important to us, and that is all the medications that you can order for symptom-based withdrawal effects. And then at the very end of the order set is the consultants that you can involve. So addiction medicine, health psychology, psychiatry if needed. And so it's a really great resource. I would highly recommend using it. And then next, we're going to talk about addiction treatment. So for patients who have opiate use disorder, thinking about medication for opiate use disorder while they're hospitalized is super important. If it is a home med, you should think long and very hard about stopping it. I have almost never stopped someone's Suboxone, and I have only stopped methadone once, and it was because it caused a cardiac arrest. You should always continue it unless you have a very, very clear indication. If you are thinking about newly starting something like Suboxone or methadone, you can consult addiction medicine. They're here Monday through Fridays. If it is after hours or it is on weekends, they have created an opiate use disorder pathway that's present in the Pulse, and it'll walk you through exactly how to start buprenorphine and what to do if you precipitate withdrawal. All right. And then additional supports that you can consider here at our institution are things like health psychology. They're really helpful in walking patients through kind of new coping skills, essentially as we take a lot of times their main coping skill away. And then thinking about peer support, this is a hotline that's specific to Dane County that can be given to a patient by the physician, the nursing team, or they can Google it themselves. But essentially there is a recovery coach on the other end who will kind of walk them through then the next steps in kind of maintaining sobriety. This is not to take the place, though, of health psychology or addiction medicine. This is just an extra layer of support. And then always think about discharge planning in this patient population. If you have someone who you're prescribing buprenorphine to, you can always try to see if their PCP is willing to prescribe it or find them a new prescriber. If you do that, you should give them a supply to get them to the time of follow-up. And if there's no prescriber identified, you should give them a week's supply and send them to our Compass clinic, who has walk-in sessions and is more than happy to refill people's Suboxone. When thinking about methadone, you always have to find someone to prescribe it. You don't send a prescription on discharge. You just provide them with a MAR, and then they will have to present to that prescriber the next day. And then again, always prescribe naloxone. Okay, and now I want to talk a little bit about multidisciplinary teams. So obviously when we're taking care of these patients, it is the multidisciplinary team of the century. It is the primary service, the infectious disease team, the addiction team, interventional cardiology, sometimes cardiothoracic surgery, health psych, case management, social work, PT, OT, nursing, like the list just goes on. These people have a lot of individuals who are involved in their care, and oftentimes it can lead to kind of, inadequate communication, fragmented care. And so there has been some institutions that have looked into how to better care for people in a multidisciplinary way. So Mass Gen actually created something called the DUET team, which is drug use endocarditis response team. And they were a group of addiction medicine physicians, cardiothoracic surgeons, and maybe infectious disease addiction and cardiothoracic surgery who would weigh in on these patients. And so it was like a more centralized consultant team. And when they had like a more centralized consultant team, they felt like they had better coordination of care, more timeliness to testing, and better adherence to evidence-based medicine. And so something that we could consider here, instead of having to consult a bunch of different services, you have one kind of team that you consult instead. The University of Michigan took a different approach to this. They also recognized that they were having issues with kind of coordination of these large multidisciplinary teams. And so they had individuals from infectious disease, addiction medicine, and cardiothoracic surgery actually sit down and make really strict algorithms that people had to adhere to in taking care of this patient population to really remove your personal bias from the situation. There was a heavy influence from cardiac surgery, I will say, in this study. So they looked at all of their patients who were hospitalized for infective endocarditis and injection drug use from 2014 to 2015. And then again, after they implemented that team in 2018, 2019. And they found that they had better time to consult in cardiac surgery, better time to cardiac surgery, more surgery during admission. So lots of cardiac outcomes. But really what they found is that they also had overall in-hospital mortality reduction. So they had a 29% mortality rate in 2014 to 2015. And then by 2018 to 2019, they had a mortality rate of 7.1%. So a very large reduction. And overall just shows that maybe some of these algorithms where we're not, putting our own personal bias into the situation may help better care for these patients. Again, something that we could consider as an institution, but obviously there would need to be reserved time for these providers to really implement that. Okay, and then lastly, this is the most near and dear to my heart. Please, please, please document a plan. Think about it, put it in your progress note, talk to ID about it, put it in your sign out for the patients who are cross-covering your patients at night. We know that documenting a plan makes people more likely to contingency antibiotics, and contingency antibiotics saves lives. And so I would love for that to be my lasting, impact on this institution. This is the dot phrase. You are more than welcome to go steal it, but it'll probably disappear as I leave. All right, so that is all I have. Before I take questions, I just want to say a couple thank yous. I really want to thank Dr. Koenig, who is out camping with his family right now, and Dr. Tischendorf, who's up there. You guys have been unwavering support for me. You guys have always pushed me forward on this project, and I really appreciate your expertise and support. I also want to thank Rosemary Bailey. She also shares an interest in patients who inject drugs and really was a sounding board as like a near peer to me. I also want to say thank you to all of my co-chiefs, Mazen, Geraldine, and Lucas, for kind of being a support this year. As Mazen said 2 weeks ago, we've had our ups, we've had our downs, we've definitely had our frustrations, but I'm so happy that it was you who I got to go through this with. And then I also want to thank my family. They have answered every phone call during residency, listened to me drone on about all the patients I've taken care of and have no understanding of what's going on, but I greatly appreciate that support. And then I want to thank Andy and Kelly for allowing me to have the opportunity to be chief. It's been an unforgettable year. And then lastly, I want to thank Dr. Schnell. She was my APD throughout residency and really encouraged me to take care of vulnerable populations and continue my interest there. And it was a huge support. All right, thank you guys.
All right, thank you, Haley, for a wonderful talk full of tons of action items for all of us Ask Clinicians. What questions do we have from the audience? I'll give it to our chair first.
Thank you, Haley, and thank you for all of your work this year and throughout residency. Very much appreciated getting the chance to work with you. So I'm just curious, in your pre and post chart review of your patients, did you document, or do you have an idea of how many of those patients had a documented infectious disease consultation? And should your dot phrase be part of the ID consult rather than relying on hospital medicine or residents to put it in? So two parts.
Yeah, great question. I would say the vast majority of patients actually did have an ID consultation. The only people that really didn't were people who were very early on in their hospital stay and really still hadn't had workup like a TTE, but met other minor criteria. I definitely think that it is a combined effort between a primary service and the infectious disease team and document a plan. I would love it if hospital medicine, our residents and an ID would all document a plan, but I think it takes one person to really ask the question before that ball gets rolling.
Kowski, see if I can get to you.
I would agree this was awesome and really a wonderful way to take quality improvement and kind of tell all of us about it. My question is relating back to the data from Washington University, where it looks like the contingency plan patients did just as well as the patients on the traditional track of treatment. So I was really curious if that contingency plan should actually be the plan. And because I think about all the days in the hospital and all that money spent, where if it could be spent on interdisciplinary outpatient care, that would serve everybody much better. But I'm curious if there was any conclusion about that in those studies.
Great question. There's actually a couple studies that have looked at this where they've looked at implementing partial oral courses after people have completed, a certain amount of time, certain amount of their IV antibiotic therapy. And the outcomes aren't as good as just IV antibiotic therapy alone. They tend to have more complications. They do tend to have more antimicrobial failure. So it really still at this point is supposed to be used as a contingency plan rather than standard of care.
A question from our virtual audience: Are safe injection kits available at UW to give to patients? I need to mention they're available through public health.
Yeah, I don't know that they're available here at UW. I've never been able to conjure one up, but public health does have them, as does Vivant Health. They're really active in our community. Maybe otherwise. Yes. There's a lot of naloxone dispensers actually throughout campus here, and across the city. There's actually like a map that you can look up through the public health department.
So once you know they exist, you sort of see them everywhere.
Yeah.
No.
Okay, that was a great talk. How are we doing? I know you didn't look at this as part of your project, but you may have noticed it from a standpoint of naloxone prescription at the time of discharge for patients with opiate use disorder.
Yeah, that's a great question. I did not look at that. I probably should have. That would have been really easy because I did go through all of those charts.
Project 3.0 for someone in the room. Yeah.
Excellent presentation. I loved it. You mentioned that IM residents and hospitalists got the education on documenting a contingency plan. I'm curious if ID was also, if they received the education or not, because a lot of times when we consult a consult service, we become a little tunnel vision and just follow what they say.
I know that Dr. Tischendorf and I did talk with some of the leadership in the ID department, and they definitely had buy-in. I don't know, Jess, do you know if like the fellows actually got education?
Yes, I did.
Yes, Rosemary.
Questions from the audience or our virtual audience? Otherwise, you've answered them all. Oh my gosh.
I will just say it's been a privilege working with you on this, Haley, and I've been so heartened by your dedication to taking care of these patients. And I'm sorry to lose you to SSM, but know you're going to do wonderful things. Have you thought about how you might take this work to SSM or understand how they're caring for these patients?
Yeah, that's a great question. I remember that actually part of my interview was talking with some people about the addiction care over there. I think they're probably in a similar state that we are, whereas it's happening occasionally, but not always. And so I think that this is definitely a project that may be applicable over there, and we can continue to take care of essentially the same population across the city.
I'm just thinking of, congrats for the presentation.
you.
I'm just thinking of patients who discharge before medically advised overnight. Are we allowed to give like a one-time dose of Dowba? I know those are really expensive drugs and pretty restricted.
Great question. Fortunately, right now, that is like not something that's part of UW's like protocol. Something that Meritor is working really heavily on because they can get people essentially into the infusion center very quickly, but cost is a huge barrier. It is something that I would love to work on UW with, but I know that we have all been getting the financial emails. Oh, Jess, help me out. Oh, way more.
Well, maybe we'll conclude there. I want to thank Haley, one, for all of her wonderful work this year and a terrific presentation today. So thank you, Haley.